Very good evening, ladies and gentlemen. Welcome back to yet another session from Online Dentistry. Kindly wait for another 2 minutes while we enter the other participants. Dear doctors, kindly register yourselves on www.onlinedentistry.in to claim your certificates for all the webinars coming in. We shall begin the webinar very shortly. Kindly wait for just 2 minutes. Once again, a very good evening, one and all. I am Dr. Devika Vaswani from the team Online Dentistry. And before we start anything, Online Dentistry wishes you a very happy Raksha Bandhan and belated Onam. We hope that you had a safe and a happy one. Online Dentistry has been shown enormous support by you all, and we thank you wholeheartedly for it. Before we begin our session, we'd like to show you a very short video of how the journey of online dentistry began. Thank you, everybody. As you all know, that our motto is to redefine dental education and take it to the places that it has never been. As number suggests, that online dentistry was established back in 2008. Our total number of offline classes that were conducted are 122. But to your surprise, the total number of online courses conducted are way more than 500. We can proudly say that we are a global family of 20,000 plus people. Well, what to say? The masterminds behind the whole system are these two men. Dr. Joby Peter Sir, MDS, Professor and Head of the Department of Pediatric and Preventive Dentistry, Annu Dental College, Kerala, is the head of the academics. And Dr. Binu Abraham Sir, Kerala Dental Clinic, CEO, Online Dentistry. Well, we all know that online dentistry is jam-packed with a lot of sessions coming up. And in the next coming Sunday, we have this very interesting session coming up by Dr. Joss Paul Sir, Periodontics for General Dental Practitioners. He will tell us how we miss very small things and that those things shouldn't be missed. So, guys, stay tuned for this. Well, this expansion session has been the limelight of all the sessions that we have ever had. We have got tremendous response on that, and to inform you that we are going to close the registrations in the next coming 4 days for this. Thank you everyone in advance for giving us great response for this. And trust me when I say this session is going to change the game of your dentistry practice. So please do not miss this session. We have another session on public demand conducted, oral habits demystified. This session will tell you how small things, small habits can have big consequences. So stay tuned for this and do not miss this. Well, for knowing more about this and staying connected to us, please contact us on these numbers. Well, coming to the start of the session, hold your tongue. Isn't the topic really interesting? Hold your tongue. Well, we will know why the topic is such an interesting one. Before we start the session, it's my honor to be introducing Dr. Joby Peter, sir. Dr. Joby Peter, sir, MDS PGDCFS. Sir graduated from Manipal College of Dental Sciences, Manipal, and pursued his post-graduation from Rajamutaya Dental College, Annamalai University, Tamil Nadu. He holds a PG diploma in criminology and forensic sciences. He has also got a certified training for tobacco intervention from the very, very prestigious NIMHANS Bangalore. He is a member of various associations like IDA, American Association of Pediatric Dentistry, and has been an esteemed guest speaker at various international conferences held worldwide. To add it to the feather of the cap, he holds the Limca Asian and Indian Book of Records for traveling 10,000 kilometers in 23 days, covering 13 states for a noble cause, tobacco-free India. Sir, we welcome you again to the webinar. It's always a pleasure to welcome you here, sir. Over to you.
Thank you. Thank you, Dr. Devika. Thank you so much. Can I share my slide?
Yes, sir. Just in a second.
Am I audible?
Yes, sir, you're audible.
Yeah. I just want to. Okay, fine. That is done. Just want to share the sound. That's also done. Good evening. Very warm good evening to all of you. And happy Onam. This is the third day of Onam festival that is happening in Kerala. It's a 10-day festival. And also Raksha Bandhan Day. Even all the Rakhi sisters I wished. So they are busy today. So you might be asking, why did you keep a program on this festival day? Every state there is festival going on. People are busy with that and peak hours. Why have you kept a program like this? Basically, this program is those people who have registered, we have requested for them to come, and majority of those people who have registered are here, so that it gives them an idea when you come for the next Sunday program, how productive, how useful, how doubts can be cleared for the program. So thanks for those people who have registered for coming. We have given a special request to them, and we opened it up from others for very last minute, so that it can be a free, you can listen what is happening around that. Thank you so much for trusting and coming into online dentistry. And let me start my session, and let me welcome you all to my college, Anu Dental College, prestigious institute, any time of your thing. So let's start. Who doesn't like to listen? It's an art, it's a beauty, and I only know how to whistle with my lips and tongue. But there are some people who know whistle better, louder, clearer with even their fingers. I'm not very good in that. I hope you might have seen, many of you are attending me knows that. So to whistle, you need a coordination of lots and lots of things that should happen. It's not an easy job to learn whistle. Even my young son said, Papa, you are listening whistling. I want to learn. He tried. It took him around 1.5 to 2 months to get that first sound of that whistling. It need coordination, and it's easy to coordinate your lips. It's very easy. You can hold like this. It's easy, but to get that small dent on your tongue, it's not easy, and you need that to do that. So tongue plays a major role for you to whistle. So simple it is, right? It's so simple it is. You whistle it is, you feel, oh, that guy is whistling. But the tongue plays a major role in do that. Now, for tongue to do this, for that simple whistling, which is a part of phonation, if tongue has to do it, it requires mastigation, it requires taste, all the function. Apart from that, it requires 8 muscles to coordinate together for that to get that dent. Otherwise, you can't get it. It has got around 2,000 to 10,000 taste buds hidden inside this. It has 6 nerves working on it. 6 nerves at a time working on it. And blood vessels are from the external carotid arteries, the lingual nerve, and the facial artery. The most important thing is it doesn't have any bones. It performs whistling, phonation, mastigation, even taste. It does it, but without the help of any bone. If you ask any muscles or anything in your body, you have body support to do that function. If you punch somebody, you have skeleton to do that. But tongue does all the functions other muscular organ does. Energize, does everything without the support of the bones also. So what is so unique in this guy to do this function? And how this guy is sitting inside our mouth and doing this function is something that we have never thought about it. Let you imagine a 7.5-year-old child walking into a clinic with a retained tooth. Primary teeth are retained. Permanent teeth have come inside. The obvious treatment plan for this is to remove the primary teeth. I do not want to ask you. You will tell yes. So the parents might ask you, sir, it has come inside. What can we do? So obviously, the obvious question the parents ask, sir, it has come inside. So obviously, we say that do not worry, tongue will push it. Yes, it will push it. It will push it into the permanent, perfect position. But now the additional, the next teeth has come inside. The moment when you say tongue will push it, this is a function which tongue doesn't have or recorded in the anywhere in the literature. This is a function we dentists have created for tongue to push the teeth. The moment you say the tongue pushes the teeth, the child will do that. The same child of 6.5 to 7.5, when it comes to 9.5 to 10.5 years of age, you can say the child is having a perfect aligned teeth with gaps, but he's having everything coming out because he started pushing the teeth. Tongue has gone down and started pushing onto the teeth because somebody told me to push the teeth and I started. Now, that is a hypothetical situation which I am talking about. Is it always that happens or not is a big question. I just want to get your attention into the topic which I'm going to discuss is this mysterious person called tongue. Have you understood this person thoroughly? Are we treating this person in a more ethical and professional way or not? I just want to share a case which one of our students in online dentistry has posted to me, had a discussion with that and how the treatment went on. It's a story, it's a pure story. You can listen. This was the first case they posted to me. It was around 7.5 or 8 year old child. Complaints was crooked teeth and teeth coming out. So they did a checkup like conventional. Every patient who comes about crooked teeth or procline teeth, they did a conventional checkup. That is a genuine thing, and found out that the child is having a thrusting habit. Tongue is thrusting. So obviously, whenever the tongue is thrusting and that cause proclination or open bite or crowding, whatever, definitely the option of the treatment plan, the one standard answer or the solution for this is to go for a tongue grip. And they went for a tongue grip. Patient has been wearing this tongue grip for many months. They were observing the patient. They're coming for regular checkup. But the problem was patient started having this habit now. With the crib inside, patient started molding the tongue or started going underneath the crib, started doing it nicely. Nobody was observing this. When they sent this video, I said, this is the video. Yes, sir, this is the video currently that is happening. Sir, what shall I do? Fine. And the crib is coming off very often, within 20 days, 30 days, or 1 month, once in a twice in a month, they have this probe patient in the clinic with the crib covered nicely in a pouch. And we go there and ask, have you taken it out? Yes, sir. This time also taken it out. They're proud. The child is very proud. I took it out. And you are already anticipating asking you, I taken it out. Why does this happen? Isn't it happened to me? It has happened many times. When I started initial practice, many times it has happened. It's all out, fractured. Every time when they come solder fracture, so you can blame the lab when the solder fracture. If the child bites onto the uh, band, you can blame the child. Are you eating metal? Why are you doing this? Why did you do that? Your bite is so heavy. You can blame the child for doing that. You have so much alibis to escape or put the blame either onto the child, onto the lab, or to the patient. But why the crib is coming out, not staying or stationary? Sometimes so many patients ask, sir, what can you have a removable thing? So many times you are coming, you give us a removable thing, that is will be better. So the question is to everyone is, a child with tongue thrusting has come. You found out it is tongue thrusting. You devised an appliance according to the protocols, you did that. But the problem now is it is not staying inside the mouth. It is popping off. What we can do there? So the aim of this webinar is very important, especially those people who are attending next Sunday. It's very important to listen to me this time, because we are going to make you understand tongue as a muscular apparatus. It is not easy as you think. It is not a conventional textbook stuff saying the indication of tongue thrusting is a fixed tongue guard. No, that is textbook, that they have given you the idea. But when you come to clinical practice, to understand this guy, you need to understand as a muscular apparatus there. It's a muscle hydrostat. That is why many of our appliances with respect to tongue thrusting doesn't stay there or dislodge, or you gave along with your fixed orthodontic therapy, you gave a crib and you did a good retraction, done, remove the crib, give fixed retainer, upper, lower, but it's not staying, it's relapse is happening, because this is a muscle hydrostat which you didn't understand. A jelly inside your mouth. Now, jelly, the definition, it's a bomb. inside your mouth. It can explode at any time. Habit. You get thorough idea about this habit, and it can be a chain reaction of other habit that is already there, or some other habit happened initially and ended up in tongue thrusting. So you treat tongue thrusting, but other habit will be still remaining there. Or that habit you treated, but you missed tongue thrusting. So it's all a chain reaction. It's like a cycle it is. You can't avoid one. So the purpose is to find out that missing function of that organ which lead to this. The way this organ molds your face and skeleton and dentition, diagnose the malformation of this function and the treatment protocols that you can apply. So that's a basic. So it's a pretty 40 minutes lecture from this point of time, which will change the concept. And the end, we have a question, and you should tell me what it is there. Is it a jelly or jelly? What is the difference between a jelly and a jelly? G for goat and J for Joby. My name is J for Joby, you can say. What it is. And you should tell me what it is at the end of this. Those who support G for goat, one side. Those who support J for Joby on other side. Or what it is. Let's see that at the end of this webinar there. If you listen each slide and go with me, then this kind of things won't happen in your clinical practice, where patient is one time ahead of you. This is not because of patient is smart. This is because of you missed some diagnosis there. So that is the point of this entire session there. So tongue, as I told you, is a muscular organ, an apparatus of digestive system, which doesn't have any bones, but very sensitive in this. So it can change its shape without the support of any bony attachment. That means you don't have to contract by itself. It can do every action by itself. If I want to fist my hand, I have to take the support of my skeleton. I need my skeleton. Then only I can do this fist or any whatever movement I want. But for tongue, no skeleton is required to do its motion there. So it's something like a trunk of an elephant. It can even change its shape, size and shape. Sideways, it can expand, it can contract by itself without the support of any skeleton. That means the muscles which are embedded are doing this function. No skeletal attachment is required for them to do that. So it's like a tentacle of an octopus. So if you look into the tongue, it's like a muscle hydrostat, are those which doesn't have any skeletal attachment, but it can generate, change its size and shape by itself without support to any skeletal part. It can become wider, can come down. It can become longer, it can come down, but no muscle is required for it to do that. That is because of the muscular organization, especially intrinsic muscle, not the extrinsic, intrinsic muscle of the tongue. The transverse and the vertical muscles of the tongue are so unique. Scientists are still studying on that muscle, how the hell it does this action by itself. So now you will be saying, Dr. Joby, arrested. The case is arrested. It is a gel. It's like a jelly. J, it's not G. You are out. It's only J. You know, in jelly, you try to press a jelly, it will expand sideways. You try to pull a jelly, it will shorten and it will widen it. Tongue is like that jelly. So it is J, Joby. There's no doubt about it. But there's no point in me attending the next part of my session. It is J, jelly. tongue is a jelly-like substance inside my mouth, stuck inside my mouth. It is J. Wait, just wait for the next session. You'll understand that. So we can say that it's like kind of a jelly. It can change its size, lightest pressure, a wind, lightest thing can change and move. It's by its own. It can do that. So then comes this soft jelly kind of thing which is inside our mouth. Can it mold our face, a hard skeleton like a maxilla, mandible? How can it do that? A tooth? Is it possible? What are you talking about it? How can it mold a hard substance, a bony substance like that? Is it possible? Let's say that how tongue molds the face. Just jelly-like thing can mold the face there. I want to introduce you to Robin. Robin is a miniature guinea pig, which has been used across the world by many scientists to study about human face. Why? Because his jaw architecture is almost similar to human being. His teeth are almost, the mandible of his is almost similar to human being. The mandibular canal, the molars, the morphology, the roots of molars, the condyles, everything is almost similar to human being. And you can see the molar morphology is also like more like a primary second E or second molar it is. So Robin is sacrificing himself to learn as more about tongue. So he said, okay, you can sacrifice me, you learn more about it. We need ethical professional practice. So he said, you learn, and he sacrificed himself. So what the scientists have done is, scientists have taken off his tongue, glossectomy as done. When he was just 6 weeks of age, they just cut his tongue and allowed him to survive. And when he was 12 and 18 and 24 weeks, they studied his facial structure. Is there any change of him without the tongue? A group of pigs without tongue, and other group with normal one. And they came out with an amazing result saying that mandibular growth is considered, the length of the mandible in those with glossectomized is considerably reduced. The lateral growth of the mandible is reduced. And finally, they came that agnatia, maxilla and mandible were affected with tongue removed. Now, there's a famous study called Tongue as a Factor in Craniofacial Development by Schumacher and Baker in 1988. And that's what I just represented you. Tongue plays a major role in craniofacial development. How? Now, I told you the architecture is almost similar to human beings. The mandible, the maxilla, the bony structure, the fusion, everything is almost similar. And this what happens when a very young child develops this tongue, the sutures are not fused, so this tongue put a pressure onto that. This jelly stick onto the palate. It stick closely onto the palate, like a sticker, not onto the tooth, onto the palate, and it puts a pressure. So what happens whenever you apply pressure to a suture? As you all know, it stimulates the suture. It puts more bonds onto the sutures, and they are not fused, so they get developed, they become wider. So one of the main component on to the maxillary development and mold the mid phase or the maxilla is the tongue. Tongue plays a major role, and where it starts, it all starts from that little gum pad stage. When the child is sucking the mother's breast milk, it presses against, tongue presses against the nipple of the mother's breast, squeezes the milk out, and that pressure is taken by the maxilla. and get wider. It get wider and wider, and you get a wide maxilla. You need the maxilla first well developed, followed by the mandible. Now, why it is happening? It's all the cephalocaudal growth gradient. First, the head develops. The sutures, the cranial sutures, the top sutures of the cranium, the basal sutures of the cranium, the synchondrosis happens by around 3. They get closed so that brain is well protected. Then comes the nasomaxillary complex, the maxilla, the mandible, vertebrae goes down, cephalocaudal growth gradient happens. So initial time of development, that pressure is very important, and only one jelly that can get stuck onto that pellet and give that pressure is the tongue, none other than that. So tongue is the scaffold. No doubt, tongue should be on the pellet. Every time when the child developing, you, me, talking, swallowing, whenever position we are, but either rest or doing a function, the tongue should be always onto the pellet to do that particular function there, because it is the scaffold that support the maxilla. And maxilla develops, mandible will just follow. And one compartment, one component which allows the tongue to go and stick onto the palate like the jelly sticker is the frenum, the lingual frenum. And the length of the lingual frenum should be minimum 2 centimeters to do this function. So minimum 2 centimeter long frenum, the patient is able to do or should be doing to lift the tongue against the palate there. Now let's see the other side. What happens when the tongue goes down? Where all condition tongue goes down, and what happens when tongue goes down? Obviously, the moment tongue goes down, maxilla will collapse or has to collapse because the surrounding tissues start compressing the maxilla. So it will, as I told you, the sutures are wide open and it requires to wider. Now the sutures will get closed. Compression is coming from both sides. So they get smaller. Maxilla will become smaller. Hyperplastic maxilla will become in a normally growing patient. So this will happen. You can get cross bites, single, multiple, segmental, full segmental, open bites. You can get crowding because maxilla is completely blocked out. Segment hypoplastic maxilla can also occur just because tongue was down and it could not support the maxilla to develop in the initial stages there. This is a case where there is mid-face, the 6-year-old. You can see the face has become flat. Mid-face deficiency is there. And when you see, many of the time, when you see, you never look the external features. We always see the occlusion. Oh, bite is inside, reverse bite, class 3. Oh, it's genetic, this. We start relating it that and we go around. But look into that. It can also happen where the maxilla is collapsed anteriorly or all around just because tongue was not there to support to make it bigger. But we dentist has to identify that. Lack of scaffold can lead into this. So what did we learn till now? Just summarize. We learn a lot of new things which you can never find in textbook in a conventional way. You might have expected, okay, tongue thrusting habit, tongue, okay, classified tongue thrusting habit, definition of tongue thrusting habit, that person classified, this person classified, indication of this appliance. You might be expecting a answer to find out your viva question or no, but you like that only because we all learned that. But once you come into your clinical practice, next part which I'm going to tell you is all clinics. Open your eyes, go beyond that and see what is happening there. So what did we learn till now? Actually, we learned about the functions of the tongue. So anatomy we have covered, okay? Anatomy we have covered, the functions of the tongue we have covered, what are the functions are there. But I introduce you, which we have, I don't know how many of you heard about it, we have heard about it, but tongue is a complex organ, and it is not like other organs of the body. It's a muscular hydrostat. It can change its shape by its own. It can be a jelly like thing. We told that. But this jelly should stuck onto the maxilla, expand maxilla to develop maxilla. That's also we covered there. By becoming maxilla bigger, you are molding the face, becoming a good facial appearance it's giving here. Now, next question is, let's go to the next part. It's very simple. Now, Dr. Joby, yes, it has got a role, fine. It should be high onto the maxilla. It should mold the maxilla. It should do all the things if it is there. We understood. It's a jelly stuck onto the palate. Good, fine. Now, tell me, what are the conditions in clinical practice where tongue is not supporting the maxilla, where it is not like a jelly sticking onto the maxilla? What are the conditions this guy is not sticking onto the maxilla? That's the next part we there. For that, you need a screening. I can tell there are so many factors are there, but I will discuss the most important factors which are, or you should look in every patient when you see it. But you need a screening form, 3-minute screening form. If you do that, you will get an idea about this entire thing, what is happening there. It's not possible to describe everything in this session. Our habit session, we'll be discussing it, even the Malambati classification to adenoids, the tonsils, the dental sounds, everything has to be discussed when you see a patient with a tongue thrusting or tongue low postured. So let us find out the tongue is low postured. Any patient with the tongue low postured can have one of these things which are being explained in this case. This I compiled it from around 82 case histories across the world, and that is this compiled case history form, which we do in 2 to 3 minutes. Let me tell you, you will get an idea what type of tongue problem this particular patient is having it. So let's see 7 important things out of many, 7 important things that you should not miss in your initial seeing of a patient. Let's start with that. Then we can go into the next level. Let's start with that 7 important, simple, important things. First and the foremost is please do check frenum, lingual frenum of every patient you are screening. Do not miss. Write it down. Take a pad and write it down. Check for the lingual frenum. Do not miss that. Every patient you should ask to lift the lip and try to touch the upper central incisor, tip of the central incisor, and not the length of the lingual frenum. Now, frenum has classified into different ways, but I don't have time to say that. But if you find a notch or some kind of abnormality into the tongue shape with frenum, that means it's a short frenum that cannot go high onto the palate. You need some more investigation if you find doubtful. If it is fine, you can say, okay, it is good. Even frenum pulling down can cause anterior maxillary collapse. So many people have seen, given 3D expansion, rapid maxillary expansion, fan-shaped expansion, they're doing it great. But have you checked the frenum? Have you checked the frenum? Is that frenum that caused that collapse or not? Have you checked that? You need to do that. Second point is feeding habits. Very important. You cannot miss is feeding habits in children. Now, Dr. Joby, you're talking about very, very young child. No, you might be thinking it. No, even 45-year-old female patient who has come for a problem with the tongue thruster, I asked this screening question, ma'am, how long your feeding habit? Doctor, I don't remember, but I remember it was 1 year, 1.5 years. I like that. Okay, fine. Note it down. It is very important. Very important when you treat tongue. You can't take it lightly. Whether old kid, you can't take it lightly. Feeding habits, especially prolonged bottle feeding. Sometimes the parents say, my parents were working, so I used to, my parents used to say that you are feeding onto the bottle. They might say it's very important for us to note down prolonged feeding or pacifiers. use of pacifiers. Yeah, I used to use that. That small tiny silicone things, no, something like that. No, nowadays kids are using. I used to use that time. In 1998, I used to use that one. My mother bought me from this, and I used to use that. They might say that's good. You have to note it down that point, because this prolonged feeding habits and use of pacifiers are push the tongue down and makes the perioral muscle to be very active, and they are used to this because it has been constantly repeated for a prolonged period of time, so they start doing it even after removing it also. They may not immediately mature into an adult swallowing pattern because they have been used, they have been conditioned into this. So prolonged feeding habit can be a factor that you need to know. Then chewing of the food. Again, another important question. I don't know how many of you ask. I always ask the child or even the adult how long you take to have food. Oh, doctor, I food, watching TV, I keep on slowly. I'm a slow eater. I keep on chewing slowly, and then I do that. It take a long time for me to take food. Sometimes when I'm very busy, I do not take any hard food. I just take some juices or something, and I study because I don't have time. I'm very busy. I'm working. Type of food that is taking. When I ask the kids, they say, "Oh, doctor, he pouches the food for a long period, and he takes only soft food." So introduction of soft food at very early age, rather than finger foods for babies, such for that, which are boiled potatoes, boiled tomatoes, boiled your carrots, all those things little bit crushed, but baby can chew it, little bit crushed, but baby can chew it. Those kind of foods, when you introduce initially, baby will develop chewing habit very young age. If that is developed very young, development will automatically happen. Otherwise, if you introduce this kind of porridge, this kind of juices, syrups and all, child do not have to chew. They forget the using of the chewing apparatus, the masticatory muscles, the teeth. They forget to use that. Because if you look into the nature, everybody in the nature, whether young and old, a young one of a chimpanzee cannot swallow the leaf. He has to chew. Everybody has to chew with the lips closed, chew and swallow. But we human beings have a unique character of chewing the bubble gums or chewing everything with wide mouth open also. We don't have any problem in do that. Only we do that. Otherwise, normally animals will never do that. They chew and swallow with the lip closed there. So this is very important. This chewing is very, very important. Types of food the particular patient is taking is very important. Even in adults, I have seen they pretend or they have preference for soft food. Hard food they ignore. They chew and take more time for adults even have to harder foods because they do not know how to chew. They don't have the habits of chewing the food there. So this is very important factor. Why chewing is important? Because when you chew, the muscles of mastication become active. It applies a pressure, makes the maxilla mandible wider, and tongue, when you swallow by chewing and lip closed, and when you swallow, you can see the tongue exerts a pressure and the suture are immature and they get wider. So this is according to the Profit. Tongue can exert a pressure up to 500 grams in an adult when it swallows. That much pressure it can put that. And this pressure is taken by the sutures, and according to the sutural theory by Wieman and Schleicher in 1948, they say that sutures are potential sites for expansion for or growth. So this pressure is taken by the suture and they expand, and you get a wider maxilla, and the permanent dentition just follows that. And whatever parameters you look in the mixed and in the permanent dentition, in the canine, in the molar, premolar, arch length, U shape, arch depth, everything if you see are normal in a patient or in a person who has got a wider arch with chewing food properly, and well developed maxilla in the primary dentition will develop into a good segment in the permanent dentition there. So that is one thing that you have to ask for. Next important thing that you have to ask for is, or look for, is multiple primary caries, especially the molars are totally mutilated. And you know, early childhood caries is another problem that can have a chewing deficiency. Look at the polyps, how many, three polyps are there in the lower teeth, and how the hell the child will take a solid food there. This child will always and always demand biscuits, bread, juice, or something soft. He will never ever like a solid food. And whenever this multiple caries comes, sometimes we extract the anterior teeth. So there is a naturally there is a gap is already created there. Now it has got a higher tendency that the tip of the tongue can come in between and can develop a habit called anterior position, low posturing can develop high prevalence there. So you need to rehabilitate this. You cannot live like this. If you are not good in, refer to a pediatric dentist or call a pediatric dentist or whomever does that, or learn and do. And you need a full mouth biting posture at this age, or 4 and 5 years of age. You can't leave it like that because it can affect the growth and development of the facial structures if you leave it like that, or it can develop into habits which can again lead into another problems which you never know. So that part also can bring the tongue down, low posture, low chewing activity, because there is nothing to chew and teeth are in a mutilated way it is. Then the next one is habit. You all know mouth breathing habit definitely brings the tongue down. If it starts from very early age, habits like mouth breathing starts very early age. In the mixed dentition, it progresses, facial features started appearing because it is progressing and progressing. And when it's come 11 to 12 years, it's typical adenoid facies, typical mouth breather, and a vertical grower. The mouth breathing syndrome will develop, and you can see all the adenoid facies are there. For him, the tongue will be definitely low because he opens the mouth always. So for him, also tongue will be done, and it has molded the face of him because he's a type of a mouth breather where he cannot close the mouth and breathe through the nose. Now, what about these two cases? These are two other cases. They are also mouth breathers, but they are not as kind of mouth breathing syndrome kind of things have not gone, because they can breathe through the nose, but they are habitual mouth breathers. So, again, we are coming into a little complicated stuff here. Mouth breathers, but typical syndrome is present. But here you have another segment. They are not have that kind of syndrome, but they have other features which are habitual mouth breathers are there. So these things can also bring the both these things. One thing is common, tongue will be lowered. Please try to understand. One is syndrome, that is different modality. One is habitual, but the different modality. But both condition in a clinically sitting in your clinic, they have something called tongue low posture, and the effect of malocclusion will be different. You can see from the facial features. Now, intraorally, you have to see to find out what are the change in the features there. Next is, as obviously, thumb sucking habit definitely brings the tongue down, and it can have the dental effect, skeletal effect, forget about it, but tongue will be low posture in these people also. So tongue thrusting or thumb sucking habit, we can break the habit. Here the problem is, that patient is having a thumb sucking habit, so your mind is only on to break the thumb sucking habit only. But what are the, and you think that, oh, all the other effects are auto corrected by itself. But if there is a widened arch, either constricted arch, crossbite, or other problems associated with this, if there is a mouth breathing which is habitual, which has happened with that, what will you do that? That is what it is called chain reaction. You started with the thumb sucking, then side by side habitual mouth breathing also started. So you can give an appliance to break thumb sucking or do counseling to break that. But along with that, other habit is that how will you find out? How will you do? That is the problem. So tongue thrust sucking, thumb sucking is also a condition where the tongue goes down. And finally, the culmination of all those things will end up in a tongue thrusting habit. That doesn't mean that all will end up in that, but I told you tongue will be low postured in all this clinical condition, and majority of this clinical condition can end up here, called tongue thrusting. On the way of the development, they can have a mouth breathing, they can have a thumb sucking, which you might have broken, but you might be hidden thing will be a tongue thrusting. The current concept is whenever you see a tongue thrusting, you see that there should be an open bite, there should be a vertical grower, that things are conventional way. But even a class 2 div 2 patient can have a tongue thrusting. A deep bite patient can have a tongue thrusting. A brachycephalic patient can have a tongue thrusting. A vertical grower can have a tongue thrusting. A normal class 1 bite can have a tongue thrusting, or can have an infantile swallowing pattern. But you need to understand that. That is the importance of this. Tongue thrusting will be the final path of ending of all this habit. It might have started with a simple mouth breathing habit, thumb sucking habit, or a ECC, early childhood caries it has started, or a lingual freedom advisor, that was, or it was started with some reason. There are so many which I cannot explain in this small session, but it will end up in this. So the tongue will go down in all those things. When the tongue goes down, our problem is maxilla will be constricted. Maxilla start collapsing there. So you need to identify. So can I start just identify tongue thrusting, just go back? No, no way, you can't do that. You might miss something. You need that meticulous screening protocol for each habit is required, and you can come to a diagnosis fine. Yes, where should I start? Which appliance should I start? Very simple. Once you know this diagnostic protocols there, then you can start applying which appliance, what should I start first, what should my stand there. So what did I cover now? Where all conditions can tongue go down. It can be a tight frenum. It can be a prolonged feeding habits. It can be a soft food liked from initial days and continued, and that's all continuing it. It can be early childhood caries that is present. It can be habits like a mouth breathing or a thumb sucking or tongue thrusting per se due to some reason, or there can be a combination which can be lead. So we need all this to find out what is happening in a patient there. So I just want to show you a case study. This is a beautiful study which has been done. There are two people. One person is Sonal. Sona, she's normal. She don't have any habits. Other person is Vaishali. She has got a habit called tongue thrusting habit. So what these researchers have done is they observed both of their external features. And if you see, let's see the external features of the first person. If you see, ask her to swallow, she's swallowing it normally. And you can't see any perioral muscular activity or anything. She's swallowed and you cannot notice that she has swallowed. But what about the other girl? When you ask her to swallow, you can see how she's swallowing. Can you see any difference in her swallowing? There is a drastic difference in the swallowing. You can see again in this video, you can see, ask her to swallow. She swallowed, nothing happened, no pain, nothing. But when I ask her to swallow, she swallowed it. But there are a lot of other thing has happened along with that. Okay. So what they have done is, what the researchers have done, they did an MRI of both the patient while swallowing. One is a normal swallower, other person is a perioral muscular activity, tongue forward place swallower it was. So those people with the tongue forward place swallower, they did an MRI. Both the people, they did an MRI. What is the difference? Let's see. Okay, we are talking about the tongue coming out in between, you doing all these things. Let's see what is happening inside in a tongue thruster or inside in a normal person. You know what they found out? An amazing result they found out is that those people who are normal swallowers, while swallowing it, the muscles of mastication, the centers to swallow, and everything is functioning normally. Firing inside the brain was normal. It was like a normal person. If you and me who doesn't have a forward tongue posture, our perioral muscular activity is not there, will be swallowing like Dick. The MRI will say that this much firing will happen in everybody when we swallow. So that means if I swallow, this much firing will happen and it is evident. But what happened to a tongue thruster? In a tongue thruster, they could see it is shooting up multiple areas. which where face is represented is been shooted up. Firing happens in multiple places. That means it requires tongue muscles, sensory, motor, special sensation areas has to be shooted up. It has to be the perioral muscle, facial muscle, neck muscle. All those muscles become active when that person swallows compared to a normal person who is swallowing. So shooting or active brain become more active, hyperactive in these people. So that is what it became a bomb, like a bomb explosion that is happening when a tongue thruster or a forward posture of the tongue person swallows that. That study is a very famous study. Please refer to 2020 article, tongue posture, tongue movement, swallowing in cerebral areas activation, a functional magnetic resonance imaging study by Fabio Scopa et al., which says activity for the brain is more for a forward posture tongue swallower. So that is the problem with the tongue. Tongue is an organ which explodes, which has to be controlled, tamed. It is not as you think a crib or an appliance can tame this guy. That is why many times I've even seen orthodontists saying that of adult, no, adult, you can't tame the tongue. You have to give a fixed retainer. That's the only solution, lifelong. It's according to that many 4 to 5 years, it is fixed, then we make it removable, but it should be fixed. Fixed. If you're a tongue thruster, it should be fixed. Lifelong retention protocol has to be done. The reason is we have not tamed this guy. It can explode at any point of time. It can just explode and can bring back that proclination, that gap, that retention at any point of time. And it can lead into other problems which you talk about it. That's why our retention, our cribs are not staying or coming out because of this guy is jelly and soft, but explode at time. Put that much pressure and take the things out because the skeleton and the muscles are surrounded and this guy is in the center. So there's a cage naturally body has created to tame this guy. That is the skeleton and the muscles surrounding it. And he is the tiger inside that hidden cage. He is tied and no bony attachments, only through the median raphe of your intrinsic muscles are the chain that is tied, and it can go anywhere inside that cage. So that is why this is a hidden tiger inside the bony cage and the muscular cage that you are talking about. So tongue is been considered as a 6-foot tiger in a 3-foot cage of our oral cavity. The famous book you must read when before you start tongue thrusting is by Felix Liao, 6-foot tiger, 3-foot cage revisited. You should read that. So what will we learn today? There are 7 clinical indicators which you can find out where tongue will be low postured. How brain reacts in a tongue thruster versus normal person. It explodes in a tongue thruster or a low tongue posture or a person who uses the forward placement of the tongue. It's a 6-foot tiger caged inside a 3-foot cage. So this is important. We have to think beyond the cage. Let's how we can mold this guy within the cage. So our aim is to find out the problem with this tiger itself first, and then come to the cage. Let us see the tiger itself is functioning normally. If he is functioning is okay, then let's see we can build the cage, make the cage bigger or not. So screening for habit comes a very important thing for the especially tongue thrusting habits, very important. So we are actually finding out this tiger, this jelly or this jelly is exploding or not at function. That is called screening of tongue thrusting habit. So I told you that the form is very important so that you can find out whether the tiger is staying can be tamed or not. So WAIS protocol is the most accepted protocol for tongue thrusting screening. Or you can use the technique of pulling down the lower lip and asking the patient to close or swallow it. Let's see both the protocol in this video demo. Both the protocols I'm going to show in the video demo. So WAIS protocol is to keep your thumb on the lower lip and your two fingers onto the cheek and ask the patient to swallow. Other protocol is pull the lower lip down and ask the patient to swallow, and you can see the pressure that you are getting onto the lower lip. So this is a WAIS protocol. You can see the contraction. You can ask the patient, see the contraction of the perioral muscle. So that perioral muscular activity is a infantile swallowing pattern, but this can be a simple and complex depending upon the other factors that is involved there. So this is the basic protocol that you can follow in your patient. Just find out these two protocols and see whether the patient is having a tongue dysfunction is present. If there is no tongue dysfunction, then perioral muscle will never contract. In an adult mature swallowing pattern, the perioral muscle will never contract and the masticatory muscle will be contracting, and the patient will be having an occlusion in the posterior segment when a adult mature swallow. You try it for yourself. Keep your finger this and swallow, and you can see the masticatory muscle is contracting, and when you swallow the saliva, and you can see an occlusion that is forming in the posterior segment there. But if there's a mature pattern, you can see a lot of perioral muscular activity that is happening there. So if diagnosed tongue thrust swallowing, then you have to screen for SPF. I call it SPF. That is nothing but tongue size, posture, and function. SPF. Size of the tongue, posture of the tongue, and function of the tongue has to be seen. So size is macro or microglotia, posture of the tongue. For that, you need a lateral cephalogram. In the lateral cephalogram only, you can see the posture of the tongue, because lateral cephalogram is taken at rest. So at rest, tongue is low postured or high onto the palate, can be easily seen there. Function, again, you need to see the frenum and other functions in the clinical examination. And again, in the lateral cephalogram, you can see the airway, upper airway, the lower airway, whether is obstructed or any kind of obstruction is there. If there is an obstruction is there, this itself can keep the tongue low. Imagine a patient is having a swollen adenoid, tonsils. Tonsils are swollen from both sides, like too close. That's a Malamberti classification, that the tonsils are too close or kissing tonsils. Where the tongue will go? Tongue has to come forward. How it will come forward? Either bring the mandible forward or keep the mandible low down. So that all things are possible in the lateral cephalogram. You can see the tonsils, whether they are swollen, projecting it out in, and can correlate with intra examination also, that can be done. Arch constrictions are important. Palatal height are also important. For that, you need model analysis. So within 3-4 minutes, you can find and tell that, oh, this patient is having a constricted maxilla. Or let me expand. I need to expand. There are some parameters which says that you need to expand. That high palate tongue cannot go. That constricted palate tongue cannot go. No matter whatever jelly it is, it cannot go into that high arch palate, that constricted palate. So you need a model analysis to find out what is there. And one important thing, whenever you do is 7 and 8 above, canine guidance is the ultimate thing. In an OPG, you need to find out the canine is properly erupting or not. So it is a combination of all the diagnostic protocols, which is not just like giving a crib. Oh, I broke this tongue thrusting habit. See, the open bite is corrected. Everything, you remove it. The moment you remove it, after 2 years, you see that again the tongue thrusting is there. Again, the patient is again same kind of proclined teeth. Again, the patient is having same that sleep problem. Same that thing will be still continuing because you have not checked anything. You just saw the condition. Open bite, tongue thrusting, I put a crib, tongue was held back. Now, because of my crib, the tooth erupted, occlusion closed out. Oh, I got a good result. No way. You need a holistic approach by identifying these simple diagnostic tools, which we can see that. This was the same case. So I told them to send me the picture. This was an extra intraoral picture. The moment I saw this picture, oh my God, the tongue is that the palate is high. I can't even see the roof of the palate. It is very high. And I told them to measure the palatal depth, measured it, it is 15 millimeter, told them to take the palatal height index Becora course, it's 636 percentage, it should be around 42, so it is reduced. So that means high arch palate. Told them to see the transpalatal width, it is 30 millimeter. Accordingly, in mixed dentition should be around 36, 34 to 36, but it is 30 millimeter at the age of 9 to 10 years. That is a warning sign. Palate is constricting again, way below that. And send them to tell the lateral surf. That gave me the lateral surf, found out that upper airway is blocked with a huge tonsil projecting into the upper airway and blocking there. And patient, when I asked them to find out whether they have a breathing problem, yes sir, they have a habitual breather. They are not a open, they're constricted or no mouth breathing habit otherwise by the parents. But when we took the history, she is a habitual mouth breather, which was masked by this problem. So can you imagine this both problems are togetherly present there. If she had have given just the crib and corrected it, if she might have missed this habitual mouth breathing there. So tongue was low posted in the self there. So in these conditions, we start with orofacial muscle exercises or training first. So that is the key. We do not start with appliances like FTG or fixed tongue guard or removable tongue guard. Start with orofacial muscle exercise. One of the most common exercises that we use is tongue click the spot for 10 seconds, 3 to 4 times a day is the one the patient will teach the patient to keep the tongue at the spot. A spot is just 5 millimeter behind the meeting point of the central incisor. 5 millimeter just behind the meeting point of the central incisor in the midline. That is just behind, or incisive papilla, just behind the incisive papilla is this spot. So ask the patient to keep the tip of the tongue there and do a click sound. Let them train so that let him keep the tongue at the right spot for swallowing there. Once he's trained into that, we go on to holding, clicking, and swallowing exercise. Slight difference from the previous one is you have to hold the tip of the tongue for a few seconds, then hold there, then click, and then swallow. So that's what. Just hold there, then click it and swallow, and click it and swallow. This exercise is being performed. So these two are the basic exercises we start off to do that. And once the patient knows where to keep the tongue and trained to keep the tongue, you can apply the remainder therapies. As you all know, fixed or removable tongue guards you can give, and all those tongue guard comes at the spot or the 5 millimeter behind there where they are supposed to give. You are already trained, so they will easily understand that. And one appliance that called bluegrass appliance, which has got a silicone bead in a palatal bar. There is a silicone bead is there which is keep on rolling. So the child has to hold that bead, stop rolling, and then swallow. Also, that is also an easy way to train to identify the spot and make the patient to put some pressure by holding it against the palate and then swallowing it by tip of the tongue. So that can also be there. It's also available in removable, but I don't know how much practical it's removable. Fixer would be much better when you use bluegrass appliance, but I do not use all those things. My favorite is by Dr. Harwold's appliance. This is one thing which I use. I make a groove at that spot area. Just make a groove and ask the lab people to put some color, red, yellow, green, whichever their favorite color. I ask them to do that onto that spot, and then I train the child to keep the tongue onto the groove and swallow so that they can easily identify. So it is easy for phonation, easily less cumbersome for the patient. No much additional gadgets are there. So it is very useful for the patient. This is one appliance which I do tell them to do that. So this is a case you can see a cross bite, tongue thrusting habit, anterior open bite. All these things are present in this patient. So in this patient, to start off, what we have done is we have expanded the arch first. Instead of giving any appliances, we expanded the arch first because it is justifiable here. Look at that arch, cross bite, constricted high arch palate. You can't ask the patient to do crib exercises or do this one with this arch. You have to expand. So expand it first, and simple maxillary expansion is all that you require. 6 to 8 months expanded the arch, get a good expansion, and then started tongue training there. So initially in tongue dysfunction patients, screen for the dysfunctions available there. Start with stage 1 with tongue exercises. And if you require expansion, slow maxillary expansion is a wonderful appliance you must learn, because as I told you, this is an inevitable part. It's like a chain reaction. You can't expand, you can't ask the patient to do tongue exercises or breathing exercises or anything in a constricted maxillary arch, low tongue posture. You can't do that. So what you have to do first, expand the maxilla. Which type of expansion? Slow, rapid, depending upon the case. How will you come to know which expansion should I give? All case can I give SME? No way. All case can I give RME? No way. There's a different specific way that you have to find out. This case SME is enough. This case RME is required. And then go for your tongue training, nasal breathing, whatever you want. But mold the face which is being deficient there. Find out that defect first. So that is what we do initially. And then hold the arch till the permanent canine erupts there. So this is simple. That's why you can see there is no crib, there is no bead, nothing to make it more cumbersome. Remove that. Just simple Howley's appliance with an expansion and a protocol to be followed can make the arch wider. Amazing simple expansion appliance. I still believe that private dental practitioners are not following it because either they fear this happens or it will work, patient will wear. Please, that's the myth that you're having it. It's an amazing appliance that you can give. Simple SME appliances can be given, and especially conditions like this require that. Then Quadlix, another appliance which sometimes you might require, or rapid max expansion. That depends upon each cases. So once the expansion is done, then we'll start tongue training, or along with that we start tongue training, and then we'll hold the arch and then goes into fixed orthodontic. So easy now. So now just align it, finish it, or even if you want the extraction, you extract it, retract it, make the patient happy, but you have trained the tongue where to be there, given room for the tongue. That posterior area, intermolar width was small, you made it wider so the tongue could go high. The nasal passages become wider so they can breathe, they can hold the tongue front. Then you extract, then you take it back. Your natural retention will be the tongue, and the other perioral muscle won't act because tongue is inside protecting it there. So that is what happened for this case. From 7.5 to 8, now she's almost 13, 11 to 12 years of age. We can see the palate, we can see the natural retention that will happen. I have to just remove the Howley's appliance and let her live with the natural tongue posture, natural retention. No more breathing, no tongue thrusting, no other habits for her. So the transpalatal width is increased from this, and even tongue can go high, not falling onto the teeth and cause again relapse there. So the face changes from this to this. You can see the maxilla widens, the mandible follows, and a wonderful result, full face development you can see in this patient there. So tongue, the final part, the tongue and sleep disorders, especially when you treating the tongue, you cannot ignore sleep and tongue. A very important part with sleep, because tongue should be high and airway should be opened when you lie down. When you lie down, tongue should never fall back. When the tongue can fall back, condition I told you, constricted maxilla, open mouth posture, retrognathic mandible, you can have tongue falling back. So that falls will compress onto the airway. Your airway, it will compress onto the airway. The tongue will fall back and it will compress onto your airway. So definitely the patient will start snoring, disturb sleep. All those things will start just because of the tongue falling back. The reason can be a small maxilla, constricted maxilla, can be small mandible, it can be a habitual mouth breathing, or it can be due to various reasons which I already explained to that. So by treating or by expanding the maxilla or holding, giving the room for tongue, it is not only preventing your tongue thrusting habit, it is bringing the tongue forward high onto the palate, sticking this guy against the palate like a jelly sticking against the palate, so it doesn't explode or it doesn't cause any harm to anyone, silently sleeps there. So that is what the reason for treating tongue at the right way. It is not that anterior open bite and cross bite is worrying me. It is not that constricted arch is worrying me. It is not this class 3 tendency that you see is not worrying me. It is not that midface deficiency that is worrying me. It is worrying me. Am I treating the root cause or condition? That is what worrying me. So is it a jelly or is it a dynamite? Gellly jelly or Jelly jelly. You tell me what it is. Can you come to the chat box and tell me what it is? Is it is a jelly or it is a jelly? Gellly or Jellly? You should tell me what it is. What you feel about this is Jellly or Gellly. It's your choice. It's an audience choice today. Let me see who or how much. I think I should have created a poll on this, but let me tell me how many of you say it is a jelly or it is a Gellly. See, guys, whatever I will keep on type the answer. I'm concluding it down. You must attend these two programs that is coming up next week. We have programmed, which due to public demand, we have programmed in such a way that you expand and find out the result and then treat habits. Many of them is other way around. They do habit correction first and then they think about, no, think about this reverse way. Try to think about it, expand and get a good arch, and then try treating this tongue, this all these habits. You can see natural improvement in the habit. So many times when you expand, mouth breathing goes off by naturally. So many times we expand, the tongue thrusting goes off naturally with simple exercises. So much improvement that can be done. So you do not miss this program. That's why we requested all those people who have registered for the expansion must be there. This program will be repeated again for those tongue people who once they get registered, because we want to make sure that you understand the concept before coming into our protocols. It's not just give appliance and write down something and go back. No, we are there to support you. We are there to give you guidance. Our many groups which have started is still there. People are interacting with us. We are guiding and have shown you cases which they have done and they have changed their way of practicing. It's a testimony which I've shown you. All the cases today I've shown. Some of mine and many of them are students who have started, they failed, identified and rectified, and they are progressing into good results I'm getting in my personal WhatsApp group. So do not think that. So let me tell you, to summarize, muscle is a complex muscular organ. You need to understand. It can mold maxillary bone. It's a muscle hydrostat stuck in your mouth. Low tongue posture, and its reasons I have discussed. It's a different appliance can be used. Tongue exercises can be used. Case discussion we have discussed. But let me tell you one simple thing: is a jelly or jelly? I think it is both. So many people have really understood that it can be soft like a jelly, but it can explode like a jelly, like a gelatin stick, jelly gelatin stick, it can explode. Thank you so much. Just want to conclude, you should meet this person, which can give you a different perspective on tongue. He is none other than
Ben Underwood is one of the kids with superpowers. When he suffered retinal cancer at the age of 3, Ben became blind. What is incredible is that he is able to see without his eyes. Ben uses echolocation by clicking his tongue, which enables him to walk without a walking stick and even play sports. This incredible young man has also taught other blind people echolocation to improve their quality of life.
So echolocation with tongue. So another function I added to the tongue, another function of not molding the arch, not phonation, not taste, not swallowing. echolocation is possible with the tongue, and it's a living example. You can search even how the snake does it with the tongue. So it's a very powerful organ. Thank you so much. You can contact us in the WhatsApp group or this personal WhatsApp group. We can contact if any more discussions or any more requirements if you have. Thank you so much. Over to Devika for any question and answer session. Thank you so much. And again, happy Raksha Bandhan Day and happy Onam belated. Happy Onam to all of you. Stay safe and sound. Have a good night.
Thank you so much, sir. It was indeed a great session. We learned so much, and I hope finally the debate has been settled whether the tongue is a jelly or a jelly with a J. So we'd like you all to put in your questions on the chat box. Sir is ready to take a few. Yeah, we already have a few questions here, sir.
Yeah, shoot it up.
Yes, sir. Sir, if an adult patient of 20-year comes with spacing in lower anteaters, and if tongue thrusting is identified, can we do aligners or should we go ahead with exercises and reminder therapy?
My genuine reason request for you is, doctor, I told you now, I am treating a 45-year-old with the same problem. Same problem. She is a 20-year-old. I'm treating a 45-year-old with the same problem. So you can start orthodontic therapy or aligner therapy, provided, as I told you, please check for the palate, transpalatal width, frenum, type of tongue thrusting, whether it is simple or complex, and start with tongue exercises. It's my request to you, please do start with tongue exercises. Now, even some labs, even the clear aligner tray itself, they might give you a hump or a small projections in that spot area so that it can act as a reminder. That is also possible if you talk to the lab, respective lab, to do that. And you can start with tongue training exercises, and then along with that you can go for clear aligner therapy, because they are paying a huge amount and you should not again end up in relapse after even clear aligner therapy. It can give you a very good predictable result, but please do start with tongue exercises. Find out the diagnostic criteria for that, and then it's your call. You can do that. It can give you a good result.
Thank you, sir. Any more questions from anyone? Yeah, so we have another one. What about double oral screen for the management of tongue thrusting and mouth breathing habit?
Yes, I did not put that double oral screen, which was there with me in one of the patients who were given. It is theoretically speaking, it's a very good appliance. Like our trainer and the double oral screen doesn't have much difference. Trainer also have that two flanges, lingual pad, everything is there. So almost same thing it is there. Now, which habit do you want to break first? Do you want to break both habit together, or you want to go little gentle, break first one and then go into the next? Now, mouth breathers, if you find the transpalatal width or if you find the maxilla is underdeveloped, I would suggest you is to expand and provide room for the tongue and even the nasal passage, and side by side you start your therapies like that. So which condition you want? See, a borderline cases you may not need to expand, but a severe constricted maxillary arch is there and vertical growing tendency is there. You just give an oral skin or double oral skin may not help it. Rather than you might have to expand it and then go for training exercises to help it. Double oral screen would be good in a mild or a borderline kind of cases. There are no much other problems, but this kind of cases you can give double oral screen.
Thank you, sir. I think that's all for today on the question answer round. Thank you everybody for the great response you have given. And we have another session coming up on 29th of August, that is expansion. So before we conclude, one special request is, what is the blind man's name that was shown in the end, sir?
Oh, the last person who, there's this one. Hello?
Yes, sir. The same person who was
I didn't get you.
Hello,
I didn't.
sir. The question is, what is the blind man's name, sir?
Nick Johnson.
Yeah. Thank you, sir.
Yeah.
So thank you everybody for the great response. We shall see you on 29th of August with the great session coming up that is on expansion. And that's all for today. Have a great night. Thank you.